Hey, what's up guys? It's Jen. Welcome to my channel, Momming with Migraine. Migraine. About that. I do get migraine, but I also have a condition called pseudotumor cerebri. My cranial pressure is too high. Over the last 6 years, this pseudotumor, or this high cranial pressure, has been building and progressing within my head. But the problem is, it was diagnosed as chronic migraine at the very beginning of when my symptoms started to occur. So as my symptoms got worse and they got scarier and other systems in my body started to come into play, like my cardiovascular system, my doctors kept ignoring it and shoving it into that migraine bucket. I could feel that there was something seriously wrong in my body, that something wasn't quite regulating right. But my doctors let my disease progress. I slowly lost abilities. My whole life was shook up because my doctors wouldn't listen to me. They insisted that I was just anxious, that I was just Googling too many symptoms. But I knew something was wrong. My story of going from a misdiagnosis of migraine to getting treated for what I actually have, which is this high cranial pressure, was not a very pretty one. And if you look back on my channel, you can kind of watch it in real time. But what ended up saving the day was when I took the leap of faith and became a patient at POTS Care. I told you guys about my time at POTS Care and how much it helped me. I did a POTS Care package unboxing for you, and I even went over all of the symptoms of my pseudotumor that my neurologist missed that POTS Care found first day. You guys came back with a million questions, and I went to Dr. Driscoll to get some answers, and we decided what better way to give you guys answers to your questions than to do a Q&A on here. I really hope that you get a lot from this Q&A session, and I hope that it eases any worries that you have that are making you hesitate when it comes to taking the leap and joining POTS Care. Please give the video a thumbs up to thank Dr. Driscoll for her time, and hit subscribe so you can continue to follow my journey. Hi, sweetie pie.
Hey!
Hey! Old MacDonald had a farm.
Hey, yeah, yeah, yeah.
E-I-E-I-O. Enough from me. This video is about Dr. Driscoll. Let's meet the doctor who changed my life. Yay! Welcome, Dr. Driscoll. First things first, Dr. Driscoll, thank you so much, of course, for coming on, answering these questions for the people in my audience who had questions for you before they come and talk to you themselves. Really appreciate your time.
Thank you, Jen. It's really an honor to be here, and I always enjoy speaking with you.
Oh, I love speaking with you too, and I love being able to squeeze in questions that I have.
Yeah, of course. That's only fair.
So I'm really excited for what we're going to learn today, and I'm excited for these guys to finally get this curiosity quenched. Mm-hmm. The number one question that I get from people when I tell them about my story, my misdiagnosis, my healing process, and how I'm going through recovery now is, oh my gosh, can she fix me too? It's the one thing they want to know about you. So,
right. I guess it depends what's wrong, right? But I think so many people, and you went through it, I went through it with an invisible illness, I'm air quoting for a reason, is that doctors are floundering trying to figure it out. We lack someone to step back, look at the full picture objectively and figure out what's getting missed here. So depending on what's getting missed, we're focusing on POTS. At POTS Care, postural orthostatic tachycardia syndrome, of course, and then idiopathic intracranial hypertension, which is fairly common also. So that's our focus right now. But my interest, although it started in autonomic dysfunction, it has spread outwards. So there's others sometimes I can help too.
Trying to decide how to word this.
Okay.
I've expressed to my whole audience, really, that you and I got to spend a lot of time together when I was getting diagnosed with my IIH. I went to you already having a diagnosis of POTS. And so for my people who are POTS patients who are hoping to kind of get some treatment from you or learn as much from you as I have, is there some option for them? Because your clinic actually books up really fast. So what can they do?
Yes, well, I'm so happy now we have a couple of options because I love the one-on-one. I do. And, we'd spend like 50, 100 hours easily on each case. digging into it. But there's some commonalities among POTS patients. And I thought, how can we change the world? How can we help many more people? And spent a couple of years putting together a package to help with what are the commonalities, how can we approach POTS, or which ultimately is generally inflammatory POTS, the term we came up with. What do those people have in common? Can we help them with guidance, education, et cetera, and at least get started on their journey? And that's been so amazing to release. So that's the POTS Care package. It's not one-on-one doctor-patient relationship. It's not a deep dive into each case like we did with you, but it's beginning with the commonalities, which can be significant for the majority.
I'm getting stutters. I'm leaky. I've said on my channel many times that a lot of the stuff that I'm doing right now to manage just those POTS symptoms, I have found in the package for sure.
Yes, excellent. I am so glad. When I went through the illness, I was disabled for over 10 years. This information wasn't out there. No one had figured it out. And I would have given my right arm, I think, to have gotten some of those answers and not spent the decade trying to peel all that back. So I'm really, really happy to be able to help others with that.
Yeah. Oh, and I was thrilled when you said that it was coming out, because
good.
Same, and I think all of this information is starting to come out. But what's beautiful about POTS Care package, or about, for me, my story coming to you, is it's different to gather the information individually and to actually have it all be interconnected for you and explained to you in a way that makes sense.
Exactly. In most POTS cases, one thing leads to another, the dominoes start falling, and to be able to start to pick those up and back up and treat it more at the source of the problem is hugely helpful. But each case is extraordinarily complex. You kind of know. No two people are exactly the same, but beginning those commonalities and all the different aspects of our health that decline, extraordinarily helpful. So
yeah. So that's POTS Care package. Speaking of commonalities, hypermobility comes up a lot, and IIH comes up a lot.
Yes, it does. Hypermobility is, interestingly, sometimes called joint hypermobility syndrome. Sometimes it gets labeled Ehlers-Danlos syndrome if patients have seen a doctor who wants to follow that criteria. But the criteria for both diagnoses is completely arbitrary. Someone else invented those, basically. So I think what we need to do is instead look at the genetics. And until we can get to the genetics, I'm hesitant to slap a label on it. What we're looking at is, despite our genetics, whatever got us set up, I'm hypermobile, for example, what is the treatable aspect to the condition? And if we ignore the treatable aspect and instead tell patients, well, you have a genetic problem, there's nothing you can do, we're leaving them to suffer needlessly, and that's wrong. So one clue I had, even in my own condition, that of my kids, was that I was triggered by a virus. So I knew that did something to me, that it wasn't all genetics and it wasn't all untreatable. I just couldn't figure out what it did. No one else could figure out what it did. But it was a huge clue. We weren't going to roll over and go, oh, it's genetic. Oh, okay. Well, we just have to accept this. It's okay. No. I mean, I was disabled. I was not going to accept that. And then, my son, he was 8 when he got sick. He missed 3 years of school and he was disabled. So that wasn't an acceptable answer. We had to dig into it. And that was hard. But yeah, there is probably a rough guess from our clinic now is about 40%, maybe not quite, are hypermobile or bendable. But 60% are not.
Okay.
So, But the IIH is interesting because that's probably closer to 70%. It's not everybody, but you have to make sure in a POTS patient that you rule that out. It's too easy to miss it. No one picks up on this, but to have that treated is life-changing, right?
Oh yeah. I get people commenting all the time, like, wow, Jen, there's a different light in your eyes. People are saying, yeah, Yeah, they can see it in my eyes. And this is, strangers on the internet. So imagine the people in my day-to-day life,
That's
it's
right.
huge. Huge
It's
for my
so
family.
rewarding to recognize and treat. It's so rewarding. I remember when ultimately mine was figured out, I was high-fiving the neurologist. We're just hugging. And I said, the rest of this, I can live with it. It was just such a relief. As it turned out, it wasn't enough. I did have to eventually get more answers, but trying to live like that. And I saw some of your old videos where you were trying to live like that. To me, it was just sometimes day to day, sometimes hour by hour, just white knuckling, trying to survive, certainly not thriving. I came to call it pretend living, just try to get through it. That's no way to live. So it's really great to be able to help people with that.
Yeah.
Yeah.
It does come down to that a lot.
Yes, it can. It absolutely can. And we've seen patients who've been sick 30 years. Imagine how horrible that is. And then the health of the brain, too. If that's not recognized, high intracranial pressure is linked to every neurodegenerative condition out there. Alzheimer's, Parkinson's. And it's very inflammatory. It decreases oxygen perfusion to the brain. That is not a good setup for brain health, certainly not long term. So I think it's important not only for today to make you feel better, to live your life, et cetera, but even in, decades from now, Jen, you should be much healthier for it too. That's important. Yeah.
Potentially protect some vision too, some of your vision.
Well, oh my gosh. It's interesting because as eye doctors, we learn that that's really one of the top dangers of having that undiagnosed is potential for blindness, right? And patients will start to lose some of their peripheral vision. They don't even realize it for a long time. But I found most of the patients we see, although not all, most don't show true swelling of the optic nerve. It's how they get missed. So their risk of going blind is much lower. The risk of neurodegenerative conditions or POTS or just being miserable is pretty much very high. And we want to help them with that. Yeah. So it ends up not being what I learned in school. It isn't all about the vision. It's not. Now, I've seen it absolutely where it can involve the vision, but it's not one of the biggest dangers.
Yeah.
I think it's brain health. Yeah.
My vision has improved though. So that has
I'm
been
so
nice.
happy. I am so happy. I do think yours was really high, right? No surprise. Preaching to the choir here. But yeah, yours was very, very high. So that's not good.
It was this high, but I was this stubborn.
That's exactly right. I relate to that, right? Very much. We're not accepting of that sort of fate.
So speaking of this, this high cranial pressure, what kind of doctor usually diagnoses high cranial pressure, this IIH?
Yeah, there are many different types of high intracranial pressure. But the idiopathic intracranial hypertension, which we're calling IIH, is generally picked up by eye doctors or neurologists. Sometimes we'll pick it up, but we've all been in physicals where the doctors look in the back of the eye. That's one of the things they're looking for. It's probably the main thing they're looking for. So because clearly eye doctors look there every time, we're trained in that. Yeah.
Moving on to number 3 here. I'm going to read this one to you because my brain is good, but it's not that good.
Okay. I'm ready.
All right. Want to know for dysautonomia patients who are like in that specialist hopping loop. They're going doctor to doctor to doctor. So they're getting the same non-helpful handouts that are saying do the salt, do the blood pressure medication, maybe antidepressant, and an anxiety medication. But then they're ignoring the huge problems like brain fog or like the fact that there hasn't been any improvement despite all of these medications, real day-to-day improvement.
Right.
Do you have advice for those patients who are just stuck and frustrated and not feeling
heard? I think that's the majority, right? And I remember being in that position. I probably went to 50 doctors my first few years, just thinking I'm just not getting to the right doctor because clearly it wasn't a subtle condition. I couldn't function and My son was flattened by it. So I just kept going to doctors. And it wasn't until I was in clinical trials where they came up and said, we don't understand it. We just think you're more aware of your own body, that I knew we were on our own. But as far as I know, all clinics except for ours is into trying to basically manage the symptoms, or in some ways cover them up. And that's where I started, like, if the heart rate is going fast, heartbeat is going fast, slow it down. But my question was always, but why is it going fast? And if we could figure that out, isn't that a better point of treatment? So to try to keep people from fainting, increase blood volume, high salt, etc. If the problem is actually one of, say, for example, the inflammatory POTS patients, of inflammation affecting the cardiovascular system, those things can make it worse. Beta blockers, for example, activate inflammatory cells. Well, that's not good. Salt, as you know, damages that inner lining, the endothelium of the blood vessels, and that can make patients worse. I find that much of what we're doing for symptom relief is keeping patients stuck in the condition. And then as the symptoms worsen, we're either accused of being hypochondriacs, or they always think we have anxiety. Always.
I ranted about that last week.
Oh my goodness, no. Oh, I was a full adult. I was 48 when I got sick, and again, post-viral. Okay, and it was dramatic. This wasn't subtle. And the doctors that came to me with, maybe you just need to meditate or something, I would just laugh and think, well, that's not it. Clear, this is medical. So think a little bit deeper, but it was very frustrating that they couldn't do it. Honestly, you know how I feel about this. I think to some degree, when women present with conditions that are a mystery to doctors, we tend to be discounted a little bit easier, where it's either blamed on hormones or it's got to be psych.
Yeah.
There's a whole lot of in between, that gets
Definitely
ignored.
happens more to women, but I've got to say, it happened to my husband as well. He was sent to psych for what he ended up needing brain surgery for, because he was mute. That's another story, but
I am so sorry.
Happens to men too, but probably more so to women. Thank you.
Oh, it's a real sin, I think. And imagine POTS hits like teenagers more, perhaps, and certainly more females than males. So if you're a teenager with this presentation, and I was an adult doctor, I didn't have a chance. Imagine that poor girl, not a chance at all, trying to explain, oh no, really, this is real. Yeah. And then I wonder about, if I had been that age, would I have wondered if I was going crazy? Not knowing your personality, not knowing, being solid in your own being, if you will. You're still figuring yourself out. Yeah. Could that just really throw you to the point where you're not even sure? I could see how that'd be possible, because it was pretty brutal. But
what would be your advice for patients who are stuck in that loop?
Well, I think the POTS care package would be great. Or even we'll give the book out. I've got the Driscoll theory, which lays out quite a bit of it. And we're happy to do that. But at least to start with, let's get away from just covering up symptoms. We should be pushing for what is the underlying problem. And COVID's actually helped with that a little bit, oddly. Right?
Yeah, right? Long COVID?
Yeah, yes.
I had long COVID before COVID was even a thing. That's very...
Yeah, me too. Isn't that something? Yeah. Where they're recognizing... That's right. That's right. Set the bar. But they're recognizing in some patients there's an abnormal inflammatory reaction, right? Something I've been jumping up and down and screaming about for 10 years. Okay, if that's what it takes, is a global pandemic. I feel so bad for the patients so affected, because they go down that same frustrating journey, Jen, where they start out, they'll check the heart, they'll check lungs, etc., and they should. Okay, you don't want to miss anything like that. And then once that all checks out, basically, then they go to, well, maybe you need to exercise, you need an antidepressant, maybe we should do some high salt or something.
Yeah.
It's the same thing, just same song, second verse, which is frustrating.
Yep. And that's absolutely what happened to me. And once again, this has brought us perfectly into our next question, which is, let's say a patient presents like me, super symptomatic, almost an obvious case. How did anybody miss this? How did anybody call this anxiety? Let's say someone with my symptoms has normal MRI, normal lumbar puncture, normal eye stuff, no papilledema. Is it still possible to have POTS and to have IIH, given that all of your tests are coming back normal?
I never had a lumbar puncture. I'm glad I didn't, because I do have hypermobility, and there's some evidence that the connective tissue may not heal properly. But I remember when my neurologist suggested it, I said, could we figure it out without puncturing that dura? Because I have a feeling if someone's not going to heal well, that could be me. And that was early in some of the publications linking connective tissue disorders to secondary spinal leaks. I was really glad we skipped it. But yeah, I was one. The MRI looked basically fine. There was a partially empty sella. And I told the neurologist, well, that could be an indication of intracranial hypertension. And he said, well, 6% of normals show that. So, okay, but if that normal has all these symptoms of high pressure,
Dr. Driscoll.
What? I know. I said, could that patient be plucked out of that category and treated? And his response was no. I was like, the common sense has flown out the window, right?
Oh my gosh, I was looking, I have to tell you this. I'm so sorry to interrupt. You got
No
me fired up.
I can tell. I love it.
Oh my gosh. So for YouTube, actually, thank you, YouTube. You've changed my life. I went back in my old doctor's notes to see, I did a video where I read out all of the IIH symptoms that my doctors missed, that my neurologist missed.
Yes.
One of the best videos ever, because it's like you said, where's the common sense?
Right.
On there, they said that I had all the symptoms of IIH, that I had a lot of symptoms. I'll say that. On that report, they said I have a lot of symptoms of IIH. My eye doctor did report papilledema. The MRI did come back with a partially empty sella.
And it's still got
migraine. Put me on topiramate. All my hair fell out. And then they're like, oh.
Oh, wow. See, you had more signs even than I did. I had no papilledema. But in one of the studies I ran, we took POTS patients.
My papilledema came and went. It was up and down, it seems like.
Okay. Well, in papilledema, some of your folks may know the optic nerve head, the margins become blurred, and then it can look like it's pooching out, if you will. So I did a study with 30 patients with POTS and 30 age-matched normals, and I just took the images of their fundus, and I was the blinded doctor. I didn't know who was who, but I was told, just guess who's who. I was like, well, I don't know what I'm looking for. But the patients that had a partial blurring of the margin were always POTS patients. It is not papilledema. We would never call that papilledema, but I would look at it and go, it's not quite right, and those usually, 90% of the time I was correct in identifying those as patients. But clearly we're missing too much, and it isn't just me, waving this flag. There's plenty of people out there saying we're missing it. But without the objectivity of that MRI, well, just in your case and in mine, maybe that was somewhat objective. Without papilledema, they can't really hang their head on it. And they hear these symptoms, and they don't usually question for IIH symptoms. They just hear headache or neck pain, and their go-to is usually migraine, craniocervical instability, tension, headaches. You get the drift here. Then the patients suffer, and then they have unnecessary procedures, and then that's horrible, and that cycle begins. So plenty of people are getting missed. Plenty. It's very, very difficult. So I think I was just meant to go through it. Because honestly, Jen, I wouldn't have gotten it either. I wouldn't have understood it because that's not what we learned. It's
Yeah.
not what we learn in school. We learn to look for papilledema. So without that, no clue, right? So it's not like the doctors being mean or incompetent or anything. I think that the evaluation protocol needs to shift dramatically. That's hard to hard to make happen.
Yeah. And like you mentioned before, it's hard to make happen without that concrete, like here is an MRI finding that we can cite.
That's
That
right.
is a thing. We just can't do that.
That's right. And we see plenty of people where the imaging looks fine or basically fine. Yeah, fundus, basically fine. Horrible high pressure. So yeah, it's tough. It's tough.
I do think part of that happened when textbooks were made before we identified these conditions. So everybody was trained on normal MRIs that perhaps maybe a lot of them weren't.
You are right. And changes like this too, it has to be established in studies, in publications, then make it into textbooks, and then the doctors take it into practice when they graduate. But once they've graduated, they're in practice, they don't really change their evaluation protocols. They just don't. They'll go to CME and change a few things, but this is a fairly dramatic change. They won't do it. They have to kind of retire and the new ones have to take over with that knowledge for a change like that to occur. And I know you and I, we couldn't wait for that, right? It's just too long. So just push ahead.
I would have been literally in bed still, just like I was a year ago.
I don't want to tell you, I probably would have looked for a cliff. It just got so bad. And it wasn't just high pressure. Other things were happening. The high pressure was secondary to all the others, head to toe misery. It's just awful.
And I'm just going to be that annoying person who points out the silver lining here, but
oh yeah, that's right.
Good thing, because look at how much of a difference you're making.
Well, you are wonderful. I can see it now, but I'll tell you, in the middle of all that, I would hear from people, oh, there's a reason for everything and stuff. But when you're suffering like that and you see your kids suffer, I wasn't buying it. I went along with the positivity for about 3 years or so. And then after a while, I was like, no, this isn't right. If all you do is just suffer, die, I'm not seeing the point here. Now, okay, I get it. but that's hard to see when you're in the middle of that.
Yeah,
very hard.
That 100% resonates right now. I'm in the newborn period.
Right.
I get you. Delayed gratification. It's real.
That's so true. That you have the joy mixed in, which is such a wonderful time. It's exhausting, right? But what a wonderful time. But yeah, with the illness, it was brutal. It really was really brutal.
Yeah, as easy as it is to joke right now that. Anyway, next question. We already touched on how high salt can be bad, even though that's the first thing that's recommended. I think I'm just going to skip over that.
Okay.
We have a couple of patients who had a craniotomy years ago, and they're still getting headaches when they bounce. Things like that. I'm not sure if that's really in your wheelhouse to be asking you about that.
You know what I will tell you, though, is any sort of skull fracture, skull damage, that kind of falls in that category. Patients can be very prone to intracranial hypertension. I would think it's not that difficult to rule that out, right? I wouldn't see a problem in ruling that out. And if that's not what it is, that's not what it is. But that wouldn't be terribly difficult to rule out.
Yeah. Okay, we have 3 questions to go. All 3 of them are lumped in this category of symptom management.
Okay.
So first one, ways to control POTS without salts and without compression socks, those Band-Aids.
Mm-hmm.
Go. That was not a question. I didn't ask a question. Go.
I think I can extrapolate from there. It's like nails on a chalkboard for me to hear symptom management, because I just like to get rid of it, right? If at all possible, no one should try to be living with POTS. I don't even like that. I don't even like to think about it. I couldn't live with it. I tried. There's plenty of people suffering out there. I really want to change the world. We've got to change this world for those invisible illness patients. There's always a reason they're sick. We're not working hard enough for them.